Good morning, everybody.
Morning.
Thank you all so much for joining us down here. I am really excited to talk to Ken today.
We'll see if that works out.
and get a little bit of his wisdom about leadership and healthcare and all of the things that I think you probably take as very natural, but all of us are really interested to learn more about. Now, in doing a little bit of research, I know that you attended Old Dominion University, and I know that one of your early opportunities for leadership was to lead some of your fraternity brothers to sell at the convention center down in Old Dominion. What did that teach you about leadership, about your buddies?
So of all the things that could have come out of that, well, you did something with your fraternity brothers. I am so glad that that's the avenue. I really wasn't sure for a moment if Richard and I were going to be friends today. So it is an interesting piece. I haven't thought about it in a long time, but I had to work to put myself through school, and so we sold concessions and, Coke, sodas, whatever you were doing at the stadium, and was able to organize fraternity brothers to be the team that would run the stands and sell things. And so if you think about what it takes to pull a team together and get folks to actually do the things we have to do for a purpose, that purpose wasn't as high a calling as healthcare, but nonetheless, we had something to do that day that needed to get done, and the people that were there at the game or the event, of course, wanted that service. And so I think in some respects, it's everything about leadership that you all know and do every day. So you're organizing folks, some of whom came ready to perform and some of whom absolutely had no intention and weren't in a condition to perform in that case. But how did you get them to actually do the things that they had to do? And so you come back to communication and giving them a reason that things mattered. And so I think when we can expand on those pieces, but if you can make it work with your fraternity brothers, you probably have a chance. And as we all know, sometimes leadership's not fun, and so you have to also have the courage to say this is what we have to do. And some people won't like that, and you just have to accept that you try and be as honest as you can about the issues. But that's not going to ultimately be where you're trying to make your lifetime friends. You're trying to actually do things the right way for the right reasons. And most people will come along with that. And the ones that don't, well, they didn't get invited back for the next game.
There you go. So you talk about team in that context, and you talk about the notion of maybe that transition that I know a lot of young leaders make from, everyone's kind of, a buddy or a friend to, hey, here's some things we have to get done, and it doesn't feel like you want to get them done. So when you're looking at, your new team leaders at MedStar, like what are the things you look for innately in them that will, you think, enable them to make that transition?
So I think you can see in young people the ones that you just know from watching them on a project and the responsibility they take, and are they willing to actually perform or act in a way that's higher than whatever their title says. Okay. So they may be the young person on a team, but they're organizing other efforts, or they're asking questions that needed to be asked. I think leadership shows itself, and I don't think that's an age issue. Experience is a different issue, and so I'm not suggesting that the brightest young 25-year-old we have is ready necessarily to take on a job that just requires more experiential learning. But it doesn't mean we don't already know that we think they have huge potential, and we can talk at some point. We have a program called MedStar Leaders of the Future, and we're trying to identify young talent that we can move into different roles, that we can put into different responsibilities, because ultimately that's where I think the greatest chance for MedStar's leadership comes from. Everybody says they'll go outside and find the next great leader. Maybe you will, maybe you won't. 50% of the senior searches fail, and it's all around culture at that stage. And who would know us better than the young leaders that came up? And the things that we're trying to work with them on, they're not the specifics of 1 + 1 = 2. It's how do you actually lead in times of change? How do you handle ambiguity? How do you handle those difficult moments, and how do you communicate? Those are the skill sets, the kinds of skill sets that we're trying to work with them on.
Got it. And so early on in your career, or I guess early on in maybe your education even.
Could it still be early on in my career?
It can still be early on.
Or is that just too late?
Well, I mean, all right. You gravitated toward healthcare. What got you really passionate and interested in healthcare and thinking about that being kind of the path you wanted to take?
So I was pre-med, had a mother who thought she gave birth to a doctor. That didn't exactly work out for her, and she's 83, and she's not completely over that, but it's just something that I'm learning to live with. But I was pre-med, and ultimately that piece, maybe the combination of organic chemistry and cutting the frog didn't work out for me. And you think back about your life, and when people say, how do you connect the dots? Well, if I look backwards to this question and connect the dots, I'll connect them for you perfectly. If I look forward and it's not exactly how I thought it was going to be, and that's probably true for everyone, and I think there's some career lessons in that as to how you make choices and what's in front of you. But back then, I'm not pre-med, I'm a finance management major, and I have to take an elective course in my junior year, and there's a healthcare finance course, and I take it. It's a nighttime course. And I don't even know at that time that there's anybody that runs a hospital that isn't a physician. No idea. And I go to this course, it's taught by a local hospital president and their CFO. And for me, it was really one of those magical moments. We were talking about healthcare and all that I think is special about what healthcare does for every community, and yet we're talking about the business of healthcare. And that was it for me, and I then started to learn much more about it. Went to graduate school, went to University of Michigan, which I would have said more proudly had we not played so poorly right against Ohio State not that long ago.
Go Blue.
Go Blue, thank you for that. Anyway, and for me, 36 years later, although we all have challenging days, there's never been a moment where I'm not so proud and privileged to have had the career and to be in the space that I'm in. And I still love, no matter the craziness, and we'll talk about some of that today, that's going on with healthcare in America from a policy and a regulation standpoint. For everybody, I always say, and I have a board member in the room, and Rosie Ellen Herring, who can now tell you all if I'm saying anything that's not true. But when we're having a day that isn't right, all you have to do is go to a hospital, walk the halls, look inside a surgical waiting room, and you realize the privilege and the moment that we have. So for me, it worked out incredible relative to that.
Got it. And so inside of a healthcare, you talk about, this notion of not even recognizing that there are healthcare facilities not run by physicians. So you do have this kind of cultural dynamic in healthcare between physicians who aren't, wallflowers. None of the ones I've met anywhere are wallflowers. And sort of the leaders of a hospital, be they a doctor themselves or not a doctor. Like, how do you bridge that? Because you've got to lead people, perhaps in something that you certainly don't know as much about maybe as many of the people on your team.
So it's probably true for every organization you're in. It's all about team. This is not a Ken Samet run organization. This is a team run organization, and you have to have all the pieces of your team that allow you to provide leadership across all the functional areas strategically and all the issues that we know. Nobody knows the exact content. You work in a very big bank, but inside your bank, there's functional areas where there's deep depth expertise, and you're never going to have worked in all of them.
Right.
So I don't go into the operating room to try and actually deal with that piece. If you looked at my corporate executive team, so the chief operating officer at MedStar is a physician, Dr. George Drass. We have a chief medical officer, Dr. Steve Evans, is a chief nursing officer, sitting in my top 9 people. And then, of course, there's business folks that you'd expect, finance folks, our chief human resources officer and the like. So you're mixing a team that certainly brings all skill sets, and you're respecting then the organization structure. Inside our hospitals, of our 10 hospitals, we have at least 3 presidents now that are physicians. That you can see that going back. And in our MedStar Leader of the Future program, one of the tracks that we have is a physician leadership program. We do this program with Wharton. We picked 25 physician leaders. We've just finished our 2nd cohort. And these are physician leaders that don't want to be traditional leaders. They don't want to be the chair of medicine or the chair of surgery. There's lots of tracks for that. These are physicians some of whom may or may not have had certain business training, but they actually want to be in Ken Samet's job. And you're starting to see that change, so we need to make sure we're giving them opportunities for that. And since we're here, one of your colleagues, Jim Matthews, sitting in the back at Healthy Companies, they actually helped us design the whole MedStar Leader of the Future program. So there's a physician track, a nursing track, an accelerated leadership program. But I think you have to bring all those pieces together. And then the other piece we've done, which is still to this day more unique than not across healthcare systems in America, by our bylaws, a third of our board, the MedStar board, are physicians. There's always one or two physicians on the boards of health systems, but you don't see a third. And that, if you think about what goes into that, we're not trying to bring someone because they're a great neurosurgeon to sit at the table and talk about neurosurgery. So these have to be physician leaders. But when you then have that interchange on a critical strategic issue, and a lay director can have physician input, management input, and if you have an organization that believes in transparency and the executive management and the board are really engaged and together for the purpose, then I think the quality of that discussion is just really raised up, and we've benefited from that.
Got it. And so you probably, I mean, I guess what industry isn't disruptive these days, but you obviously are in an industry that's very disruptive. And so you just talked about this notion of creating kind of this conduit for future leaders who are physicians and so forth, and I'm guessing you had a real hand in laying the groundwork for that. Is there a difference between leading in a disruptive environment, a disruptive industry, and sort of even a turnaround or even a startup? Is there a real difference in leadership there?
So I think that certain leadership trends are, you could argue, would be the same. I think it's a terrific question, and I think the short answer is I believe absolutely. Because of the requirements, right? Because you're actually having to lead in times of uncertainty. You're leading and trying to get people to follow and organize together, and you can't tell them with certainty that it's going to be that way at the end. We're not just doing, again, what we know works, and we've got to get at this, and we've seen this story before, so if we do 1 + 1, it will equal 2. Now what we're talking about is we're going to do 1 + 1 for the generations we're working with now. We're going to explain why. Here's the thought process. Here's what we think is some of the likely outcomes, but you have to have both the courage and the confidence to be able to lead in these times of ambiguity and to say, this is how we see it. It's very likely it won't be exactly that way, and we're going to mid-course correct, but are we directionally correct? If you're not directionally correct, at some point senior leadership called it really wrong, and that's a whole different question that, Rosie, I don't mean this, that the board has to actually have about the CEO. But if you're directionally correct, then of course you're going to have to build different off-ramps and the like. And so then what becomes more of a requirement is communication. There's never been a time in my career where the requirement for communication, where openness and transparency and that dialogue from leadership to all members of the organization has been required. And there's no elevator talk. You know, you always want to say, well, you see that person, it's the classic thing we all learned, right? What are you going to do between floors 1 and 8 so they get your business strategy and they understand all the issues? I understand the premise. But the question now is, how do we communicate differently? And so for MedStar, we have 30,000 associates, and they all do important, heroic work, but they also go home and they sit around their kitchen table with whomever they're talking about. They see every headline in the paper about healthcare. They see the disruption happening. Yep. And how do they answer the question from whoever's asking it to them? Well, tell me about your organization. Is that a good place to work? Do you think that leadership has a clue? I mean, what are the kinds of things you're working on? I see new MedStar things in the community. What do you know about that? I think the ability for our people to have a level of understanding is critical, because they're the ones that actually are having to live through the change, right? You asked me a question, and I'm privileged to lead through the times of change, but you could argue it's even harder to come every day on the front line of healthcare and perform in the middle of that change, and I think they have to have some grounding. So from a leadership standpoint, comfortable with leading in ambiguity, the ability to accept that you're going to be wrong, but you can still lead. And what does that mean? How do you communicate? What do you own on that? And what are you doing to help your people to be able to perform behind that? So I think it is uniquely different.
So even with that sort of ambiguity, if we can kind of peer down the road, well, you can't go more than 5 years doing this, but what would you say kind of is the future of the healthcare system from the perspective of a leader in 5 years?
So I think you have, let's take this question and have two start points. And I'm going to answer it as the leader of a legacy healthcare organization. Because if we're sitting and you're the board of a PE company and you want to invest in healthcare and it's 18% of the GDP, is a different leadership moment if you say we're simply going to try and start up a group of urgent care centers. We've got outside funding and we're going to run this slice of the pie.
Got it.
So and I think your question intended for, you're running a big legacy, traditional hospital-based company. MedStar's a $6 billion organization. I talked about jobs. We touch 1 in 5 folks. Historically, we were a hospital company. Years ago, when I had the privilege to run the Washington Hospital Center in the 90s, we're at 85 to 88%, all of our revenue coming from acute dollars. When I became the CEO 11 years ago, that was about 70% of a $3 billion company. Today, it's 44% of a $6 billion company. And that's ambulatory sites, physicians, it's insurance, it's walk-in prompt care centers that you see. It is the change of what's happening. And so 11 years ago to what do we see as the future? The challenge for me, and I came from being inside the organization, I was the chief operating officer, so how do you have a different message as the CEO from the COO? You're in the same organization. And it's not that the previous administration at the organization was wrong. It's not that I disagreed with that. It's that the times changed. And technology and information and disruptive competitors. And so the requirements for the next 10 years were different than the requirements from the last 10 years. People ask that all the time. Well, why didn't you do it sooner? Well, you're trying to do strategically, operationally, from an execution standpoint, what's right for the moment and building for the next moment. And so when I became the CEO, one of the things we said was that we were going to have to disrupt our own model. We called it a distributed care delivery network as part of our MedStar 2020 vision. And we went from 70 sites of care in 7 hospitals to 300 sites of care today in 10 hospitals. We went from a hospital-focused company to hospitals being critically important, but now I use a puzzle. You know, if you think about puzzle pieces, there's no MedStar without world-class hospitals. But if it's just hospitals, that's not where the bulk of care is going to happen, and all the disruption in the future is going to be more and more away from hospitals, and that has lots of implications for a legacy company, for leadership, and for communities. And so when you look out to your question of 5 years from now, and we're just now starting to think about strategically, Rosie actually chairs the strategic planning committee, what's the 2030 stake in the ground going to be? What's that true north that we're going to pick? So here's what I do know. And then we'll directionally be right as we build the organization.
Right.
So the continued evolution of big data, actionable, information being ubiquitous in a way that then actionable meaning predictive analytics, the ability for AI and other developments to actually take this data, big cohorts of data, and change how care gets provided because we'll know more about you and how to take care of that. Individual physicians, historically, they're super smart. They're bringing everything they know, and medicine's changing so quickly. How can one person understand everything at the moment? And that's why there's such variability across the country and across our city in terms of how healthcare gets provided. So information and the continued evolution of technology. I always hold up my hand at this point. And so that's my smartphone. And it is incredible, as you all know already, what you can get in that. And the interactive devices that are getting developed today that will attach to your smartphone, that will let doctors, nurses from call centers actually do things with you on your health care is going to be even more significant. So what does that do? Information and technology, that allows care to get distributed even further. We said hospitals to big ambulatory boxes. That's going to say, well, maybe you don't have to leave your house. You just, right? It's a whole different level. And once you ease the burden of entry, think about any business you want. There's nobody that's actually, it's really hard to build the next hospital. It's not that hard to actually have funding and around an app create a new interactive healthcare company. And you're seeing that happen all over the place. And what that does then is it breaks down barriers for access. Because probably the number one issue in this room, here's a group of leaders, you know, everybody in Washington, you have full access to health care, and yet there's never, ever a week that one of you, generically, doesn't call me or call Rosie and say, I need an appointment and I can't get in. Access is the great issue, and it impacts quality, safety, and cost. And so as the field gets distributed, access will be easier. The price point will be lower. And that's going to happen. That's going to disrupt our model. And so then what does that say about what we have to do to work in that space, and why for us? Because we have to protect what only hospitals can do. We run the adult regional burn center in the nation's capital. On 9/11, the only non-military aircraft in the air was MedStar helicopters medevacing the burn patients into the Washington Hospital Center. I'm super proud about that. But think about that. There are 20% of the hospitals in America, 1,000 hospitals that are publicly held or privately held, but for-profit hospitals. There's not one burn center. You see lots of competition in this region, people trying to open up, other competitors trying to open up all kinds of services. Let me know when you see the headline when somebody wants to open a burn center. The reason is the economics aren't there for that. I'm proud of it because it's a critical part of our mission, and you shouldn't want to live in an area that doesn't have that. But for us to protect that, we have to do all these other services, because that's where the cost shift comes. Nobody can actually afford to pay for what it actually costs to have burn care if you're unfortunate enough to be in that unit. So let's oversimplify that. $6 billion MedStar, $2 billion of it is the top of the pyramid. That's the quaternary tertiary work that we do. There's no app, there's no Google, there's no Apple. Nobody's going to take that away. The problem is we need the $4 billion on the base of the pyramid to make the business model work. And that $4 billion is getting disrupted and will be much more disrupted 5 years from now. So we have to have the courage to accept that that's going to happen. We're leading a legacy organization through times of change. Future leaders have to understand that we have to live through the times of walking the hall. I have an ED doc or an ED administrator more likely that says, Ken, you opened up that prompt care center near us, and so our volume's down. So you're hurting that's left hand, right hand in our own organization. There's some truth to that. We have 200,000 visits a year right now in our walk-in centers. About a third of them would have come to the emergency department. In the short term, we would make more money if they came to the emergency department. Even though you would have waited, the patient would have waited 4 hours and had a terrible experience. But economically, we'd be better in the short term. But somebody else would be doing those same walk-in centers, because that's where people would get better care, more convenient, better price point. And so how do we put that together in a way that works? For us, we know about a third of those patients have no primary care doc. We try and make that connection right when they're in there. 10% actually need an orthopedic appointment. We make certain they have an appointment in a day. Now you're seeing how the business model starts to come together for us taking a loss lead on the front end. And so, again, I think we're trying to build then for that future distributed world. It is going to be a transparent world, and we're going to have to understand how to be competitive in this new world and to do what only we can do. But if I come to PNC and say, I need all your employees to pay more for these services they can buy in the free marketplace because you're helping to run the burn center.
Right.
You'd say, I hear it, that's your mission, that's not my mission.
Right.
So, I'll come to your foundation maybe when this is over and see if we can get some help.
We can chat about that.
Yeah, exactly. So, I think that is that future state, this evolution to distributed care, to access convenience, to convenience as a brand. Look what Amazon's been able to do, and nobody would ever think about healthcare that way. But the story I like to tell to prove that point locally, about 2-3 years ago, we've opened up these prompt care sites, and I'm talking to my daughter. At the time, she was about 26 years old, and I said, at the end of the day, so I say, Lauren, how you doing? She says, well, I didn't feel good today. I thought I had strep throat. I said, oh, well, what'd you do about it? She says, and she lives in D.C., she says, I went into one of the walk-in centers. I said, oh, great, which one of our sites did you walk into? There's 5 seconds of silence, and I'm like, wait, you didn't go into a MedStar center? She says, well, Dad, I said, your name is Samet. There's a problem right now. And she said, I looked on my phone. There was whatever it was, Joe Blow's walk-in center right around the corner. I wasn't that sick, Dad. I just needed to go in and get a quick strep test. I'm fine. If I really needed health care, I would have come to MedStar. So once I got over the shock and awe and complained to my wife about her daughter, then you stop and you think about it from a leader standpoint. What is the importance of that moment? So here's that generation, didn't see that as a real healthcare event. We, though, if we're building out 300 sites, we don't want this to all be transactional. We need you to think there's a reason to go in for this relatively unsophisticated care in an urgent care center, right? But we need you to think it matters that we're in the MedStar network, that site's different than the site next door. That's the value of the brand across the entirety. That's the stickiness we need for patients across, and we have to earn that. And I'm not suggesting that that's a done deal at all. I'm just saying that's what the future's going to be about.
It's funny because I just sat here and listened to you describe that, and you could have been a bank CEO. You could have been describing banking, particularly retail banking, and the exact challenges that you just outlined are exact challenges that our bank CEOs face each and every day, including the cost of capital associated with keeping and maintaining a model now while thinking about the future model. So I think it's that disruptive nature is just around our.
I think that's true. You know, the interesting difference, we think about banking sometimes. You all, as an industry, have been able to use automation, though, as a way that really took price point down. So there's less people in branches. If there is a branch, you can do more and more banking just through the machine.
Sure.
When you think about to date, although I think some of this will change, but to date, the big advances in technology in healthcare haven't brought the price point down because they've ended up being additive. So you had, whether it was an imaging from an X-ray to an MRI to the PT MRI. I mean, everything's been added to the doc's order twice. We've seen some advantages in the back office around technology, but on all the care sides, there's still a person that's involved. It will be interesting to see on this what happens with telemedicine. I think that'll be a big piece of the next frontier because there are huge economics if the consumer, if the patients are willing to actually interact in that fashion.
Yeah, absolutely. So we've seen over the course of the last, I'll call it 12 years, really a couple of different visions, right? So I first became kind of connected to the notion of healthcare being, something we need to pay a lot of attention to when it was actually 15% of GDP growth. Now it's 18% to your earlier quote. That's a huge, huge number. It's an amazing number, and it's growing rapidly. So, but we've seen two visions of that. So if Ken were king,
I love this.
Ken were king, what 2 or 3 policy considerations would you sort of impress upon our market, our American market, to help kind of give us a marketplace that makes sense?
So I appreciate the simple question, and this question is more complicated in today's world because of the polarization around politics. So my answer is intended to just talk about healthcare, right? I'm not really trying to make political statements either way. So isn't it something that in these days you actually have to say that as a qualifier, but it's a true and needed statement, which will then let me answer some of your questions. So there's certain pieces, forget the legislation. If anyone thinks that coverage doesn't matter and shouldn't be there for everyone, well, then they're wrong. Because everybody's going to get health care at the moment they absolutely have to have it. Unless you tell me that someone can show up at an ED door, they're in the front of GW's ED, they're holding their chest, and are we going to just let them die there? Now, if you're homeless and don't have a bed for the night, you can knock on a hotel door and you don't get let in. And if you're hungry, you can knock on the Safeway door and you don't get fed. But we've made a decision as a society that healthcare is the backbone of society as the ultimate safety net, and it's a right. So we've already got the government involved. For those that say the government shouldn't be involved in healthcare, the government is involved in healthcare, and we have laws that actually mandate that. And by the way, I'm glad for that, because why would you not? I wouldn't want to live in a place that didn't take care of everyone. So if you say that, well, who wouldn't want that? Then you say, well, then coverage matters, because coverage actually in a thoughtful way. Again, I'm not speaking to legislation, right? We can write it in different ways. But if everyone actually had coverage, which in some level then creates access at a different moment, not access just through the ED on the back end, but access in a thoughtful way like you all get if you keep up with your physicals and you can see your physician and you can get basic meds, we'll actually over the long time manage healthcare costs down. Because by the time you come in and you're really sick and you need a big intervention in a big hospital, we're going to take great care of you. You're going to get heroic medicine, and it is expensive medicine. And for a lot of it, it didn't have to be there. And one of the things that's consuming so much of healthcare costs right now is chronic healthcare. So if you have congestive heart, diabetes, think about some of these issues. These are the things that could get managed if people had access and coverage in an organized way. If, God forbid, you have something tragic happen to you, it's a car accident, it's a terrible cancer, those are one-off events they'll happen to a certain percentage, and we'll just have to deal with that way. And the wellness and other factors are all good. That's a long-term issue. It'd be good to have a healthier population. But in today's 18%, it's around the chronic care piece. Certainly around pharmaceuticals, there's a whole legislative piece that this country should take on relative to drug pricing and what's taking place in those kinds of on those kind of issues. And then the third real issue that no politician wants to talk about is end-of-life care. We spend so much money on end-of-life care in ways that other countries don't. And it's the hardest issue because you can never talk about it if it's my mother, right? Everybody's in that moment and they want everything possible. But if you thought about it as a society, you would say at some point, is it worth doing some of the Herculean things that we do when the physicians are saying, if you do this for this 88-year-old, perhaps we're extending life 3 months, but we can't actually fix this. The question is that the way that we should actually utilize both those resources? And if you ever were in the ICU to see that moment when a code team gets called for an 88-year-old frail elderly, what those physicians and nurses and the code team have to do, you'd have tears in your eyes, and some of them do. Because it's not what you want if you understood it, but we can't have a comfortable conversation around hospice care and palliative care. But if you really understood it, it's actually a really thoughtful, humane way for someone to enjoy the end, to be the end of their life with their family. There's huge dollars back to policy issues all around that. And then finally, I think we have to understand, because we're not going to stop the free marketplace, so then we just have to think through how will we handle certain safety net services. Because geography matters. Burn centers as an example. Right? So there's certain safety net services in certain geographies where we probably need the government to have some sort of a structure. And then you really can say, once we level out for that, well, then we really can say, let the free marketplace move other pieces. What you're not hearing me say is that I want the entire U.S. healthcare system to move to a Medicare for all, or the federal government to run the entirety of the U.S. healthcare system. I find that to be not something that would be supportive of future innovation and things that I think America and the free marketplace will do inside 18% of the GDP. We just have to have some level set starts. Maybe my last comment, there's some noise out there now about pre-existing conditions that you may have heard about. So pre-existing conditions got covered in the Accountable Care Act, and there's actually some discussion by some to say, well, that shouldn't be covered either because they're focused just on the legislation. Leave politics aside. Come back and think about that. So you have a pre-existing condition. You want to move from PNC to some smaller company that doesn't have insurance that's not now going to cover you because you have pre-existing condition. But you're your neighbor, you're walking around the streets here, you have this. Eventually the hospitals are going to take care of you with this. It's thoughtless. Of course that has to be covered. It was one of the great things that got put into the legislation. But we're so politicized relative to talking about healthcare that we're forgetting, can we get back to these fundamental issues? Because I think if we could do that, well, I think people on both sides of the aisle would say, well, of course you should be covered for pre-existing condition. So let's agree that's in. Let's talk about cover. Let's talk, right?
Right.
And eventually you have to figure out economics. And then the last piece of it is, and no politician wants to say this to Americans, you, Ken Samet, we own our own health care, right? We're a major player in this. We have to have some responsibility. You have to be accountable for some of your actions. You live a certain lifestyle, you do certain things. That's your choices. And the only way, I'm not suggesting they're not going to get care if they do that, but there has to be some economic issues, some economic differentials relative to how you then buy insurance. If you've chosen to smoke 3 packs of cigarettes a day, your insurance is going to cost you something more than the person that doesn't because of the likelihood of your intervention. It's just, and you give everybody plenty of notice on that, people would know that, and you have to have some responsibility. If you think about how almost all of us have grown up in healthcare, in terms of a utilizer from an insurance standpoint, we've had very little skin in the game, right? You pay your copay, your deductible, whatever PNC does, you're in for a few $100, maybe your family caps at a couple $1,000, and basically you can then consume anything you want whenever you want. There's no other commodity, if I use that word for this purpose, there's no other commodity you buy in your life that's like that. Right. And there's no other insurance policy, if you think about medical insurance compared to your homeowner's insurance, that actually works that way and incentivizes it that way. But that's the system we created. So now I think we're at that moment to think about how to evolve that.
Part of it is that's the way we've sort of trained ourselves. Mm-hmm. And so now we have to really have a conversation where we retrain ourselves for something.
Well, and think about the incentive. So your PNC, when it all started a long time ago, those insurance benefits were part of your recruiting platform. You just wanted to get people, and by the way, the tax law says you get a tax deduction for that, right? It's a pre-tax expense. So we created, if you actually step back, we got the system that we created. Why do we do so much imaging in America? Because we said we'll pay 4x if someone does something, an intervention, an image, versus an internal medicine doctor talking to you and trying to understand what's going on inside of you. So we created that, which meant that big companies, GE, Siemens, Philips, they built all these machines. And by the way, all of us Americans, we want that. Right? If somebody says you need to get an image because you have an undiagnosed head injury, I'm not sure what the doctor tells you, it's not urgent. Next 3 or 4 weeks, there's zero chance you're waiting 3 or 4 weeks. And the only way to meet that demand is we built out a system that can supply that. Sure. When I was in grad school, so it's 4 years ago, the stat at the time was that there were more imaging equipment, more MRI at that point, more MRIs in the greater Detroit metropolitan area than there were in the entire country of Canada. Now, in Canada, remember, you have a national system. If you're not urgent, you would wait back then somewhere in the 8 to 12 week time frame for that image. People didn't die in the streets of Canada because of that. Their health statistics aren't different. So again, if you step back, we got the system we created. It's been a huge engine for America. It's a huge job issue. That's the other complicator. Think about this area. If you take away the government and the schools, the biggest employers in this area are big healthcare systems. And so when someone says, I want the cost of healthcare to go down, and 56% of our costs are people related, at some point you can connect dots. And even some of the changes that are happening. I'm not saying that to say it shouldn't happen. Right. I'm just saying this is why it's such a big, complex issue, and everybody has a vested interest. Either you're a purchaser and you're watching your benefit cost inside PNC. You're a consumer as an individual. Somebody talked to me over coffee about their own daughter who was in and had a health care. Everybody cares. Or you're running a company that sells into MedStar or anyone else in the area. So everybody's got a vested interest in this 18%. So everybody says we better get control of it. Let's cut it down, or let's cut the rate of growth. Right. But please don't move my cheese.
Got it. Let me pivot because there's one other issue I want to just chat a little bit about, but also I want to give the audience an opportunity to ask him questions as well. So this is my pivot to you to begin to think about those questions. So you and I got an opportunity recently to talk a little bit about talent, about workforce, about just that 56% of your expense base and the future of it. And so when you think about the talent requirement for not only the business you're running now, but the business that you're pivoting to over the next 3-5 years or what have you, and this marketplace, very vibrant marketplace, and I'm cheating a little bit because I know some of your answer, but share with the audience, what do you think about the notion of creating the workforce that you're going to need in this marketplace? How challenging is it, and what do you think needs to happen there?
So I think it's the number one imperative for all of us and all of your businesses, right? Where's your future workforce coming? Who's going to carry out the mission and the important work of your organization? Will we have the talent that we need? So if you think about a future world of tech and digital and information, are we training people for that? So that's one sector for an organization like MedStar. Are we actually having enough folks that see nursing and medical as an area to be in, and how significant of a commitment that is for them? But do we continue to remind them, despite all the business craziness, that it's the most heroic work that anybody can do, and that mission will drive folks to be there? And then inside MedStar, we still have thousands of folks with an 8th grade education doing a lot of important work that touches patients every day. And they're good jobs, but they're jobs that over time won't be there in the same numbers. So what do we do with that, both today and future workforce, to evolve their skill set for that future world? The other piece that, in my answer to that through a unique lens, so if you're a hospital, if you're a local healthcare system, if you're a university, maybe there's a few other organizations, but we're not going anywhere, right? So there's lots of organizations that have built new buildings, whatever, in Northern Virginia, wherever they can go where they want to go. Their business can be moved if they want it to move. hospitals aren't going to go anywhere. We have hospitals that are here more than a century, and they're, despite all the things that matter from a leadership and a people standpoint, we need a vibrant community, right? We're going to be, in many respects, we interact significantly, and of course we are that. We look like the community, and the economics look like the community. And so this underlying issue, which is growing, of the have and the have-not, and the ability for all of our people to be successful and vibrant and work and then be the community that we provide care for, is a business issue. It's a moral issue, but even if that's not your boat, it is a business issue for all of us to care about the communities that we work in, and that can't happen if eventually jobs matter, right? No matter how you cut it, it's the number one differentiator of health outcomes in this country, economic status. What drove that economic status? Education, right? So, and I appreciate, as you do, and I knew you were very good to bring this group together yesterday. It's a long-term fix, it's a complex fix, and guess what? That means we have to jump in harder, not run from it. It won't all get fixed on our watch, but having been now in town a long time, we're seeing these issues escalate, not improve.
Yeah. Well, and the other thing, and so Ken and I are on a group focused on this with the Federal City Council, is this notion of not only haves and have-nots on the demand side, but on the supply side. You know, some of those folks that you said have a great education, they're providing great services today. What is their future in terms of that? Because those jobs will shrink. You know, in my industry, you know, when I joined it 15 years ago, roughly about half of our 30,000 employees were retail, and about half of that half were tellers. Today, that number is much smaller, to your earlier point, right? We have less bank branches, and the bank branches we have are smaller. And so those entry-level jobs, great jobs, but there are just not as many of them. But there's still a lot of people. So.
I'll give you one example. This is a Baltimore City example, but it could certainly work in the district. So probably 15 years ago, we worked with the Baltimore City Public Schools, the Vivian T. Thomas Health Academy now is what it's called, and we created the health track. And we had some supporters from a couple of other big organizations, IBM, a few others, and these were kids that were not going to be nurses and doctors, but the school themselves said, but these kids aren't on a track that it's too late to bring them back. It was 9th, 10th, 11th grade, and our people worked with them all through the school year. They wore white coats during the day. We brought equipment in so they could work on that. They had summer internships with us, and we were focused around lab techs and radiology tech positions. And if you think about a radiology tech position, once they came through that program, they had one more year of training after high school, and they all got jobs, guaranteed by us, but truthfully, they could go anywhere because these jobs are in demand. $55,000 to $60,000 a year start jobs, as opposed to kids that likely would have come out of that high school and worked for minimum wage at whatever job they were going to be in. We had a business imperative. It clearly also did really important work there, and it scaled up. And this is when we're collegial. After we were doing it for 5 or 6, 7 years, it got a lot of notice in Baltimore. Our colleagues at Hopkins came and said, "Would you allow us to come in and partner?" Absolutely. This is an all-win. We need scale on this issue. So some of this is opportunity for these young people, as you all know, right? That's the luck piece, right? Like where was your kid born, and what channels were open to them versus somebody else. But we have a business reason, as we were talking yesterday, to deeply care about this. If in addition to everything else that matters.
Got it. All right, the best questions are going to come from you guys. So who wants to ask? We'll start with
Hi, Ken. Thanks for being here today.
Sure.
I was wondering if you would speak a little bit about your insurance business. When it started, what the rationale was, how it works out for you on the bottom line, what it means to your business.
So part of planning for that future disruption, today we have about $600 million roughly. So not quite 10%, right in that range of our overall business. We're in the Medicare and Medicaid space, and then we have a plan for our own 30,000 employees plus dependents. We're not in the commercial side of that. So the great race happening right now in healthcare, and you can watch this with big companies, is who's going to control the dollars at the top. It could be premium dollars for insurance, but let's just keep it simple and say that's what it is, to then manage the care for a cohort of people. It could be enrollees in a plan. It could be a population, a cohort of diabetic patients that we take responsibility for from somebody else's plan. and ultimately the ability to manage that care and hopefully have a few cents left at the end of every dollar to reinvest in the company. If you think about United Healthcare, one of the biggest commercial insurers, they have a company called Optum. They're buying everything in the world, surgery centers, dialysis centers. They employed 30,000 physicians last year. They're buying everything but hospitals. And by the way, they have a $90 billion market cap, and they've got millions of enrollees. So that strategy for them is exactly what I just said. They realize that the 17, 18% that insurance companies historically have gotten from what they call marketing and administration fees, that's not sustainable for them either, right? Why would PNC want to keep paying that? People have to earn that by saying we can manage the cost of care down. Back to the other disruptive comments I've said, if they're going to do everything but hospitals, that means they intend to buy hospital services as a commodity in the spot marketplace. We can't let that end up being where we are. And who better to manage care, with all respect to insurance companies, than the organizations that have doctors, nurses, pharmacists, therapists? That's the business that we're in. But we're not completely ready for it, right? We've never actually managed populations. We managed units. You came to see us in a hospital. We knew what to do in those 4 days. It is different managing you over a longitudinal period. And so we said, let's get in up to our ankles. Let's not jump in up to our necks on the first shot. And let's learn how to actually do that and to build the kinds of things it takes to do that. We've had really good success in the Medicaid population, significant in Maryland. We used to be significantly in the district. The clinical outcomes, the care, the service, so much better for those patients. In the Medicare space, you're focusing around a chronic piece. We've had mixed results in Medicare. And the challenge on Medicare, and really it's the insurance challenge, you need lots of patients, right? This is size, because there's always going to be patients that have difficult outcomes. And they call it adverse selection inside insurance. So if you have a small number of patients, a few patients will turn the financials completely upside down. So that's why you see all the insurance company mergers that happen. There's only 4 or 5 big insurance companies left in the country. They aggregated up so they could handle that. The problem for organizations like MedStar is to aggregate and get bigger. We have 130,000 enrollees. At 400,000, our variability would be better. At 400,000, we have to have a whole nother, $500 million of capitalization sitting on the balance sheet to afford that. That's a size and scale issue, which gets into other kinds of issues. So what I would say is, I'm really glad we're in. We're learning so much about how to organize care. It has to be an even more important part of our future. We're taking our lumps along the way, but we're a big company, and we're learning how to do that. And we've done it in a way that, back to the Wall Street side, we've never missed on our projections on our numbers. And just a year ago, May, we got another upgrade from S&P to a full A category, and we sold $500 million worth of bonds to build the new Georgetown University Medical Center. So we're making it work on our story. I couldn't sell the strategy if it also took our numbers upside down. By the same token, we don't have to maximize our numbers today, and we're not. We're not optimizing them because we are making these investments for the future. And I think you'll see more and more creative partnerships along those lines. Inova did a partnership with Aetna. That was their attempt at trying to figure that out in the Northern Virginia marketplace. Up in Boston, Partners bought, that's the Harvard Medical School system. They bought a big Medicaid plan. Now, they went upside down on their financials. They jumped in up to their neck, and you can see them reeling it back, but what you'd hear from them publicly is they're not running from the strategy. They're trying to figure it out. So I think there has to be more and more of that. And again, just think about that United situation. That's the battle line. Big systems aggregating up, big insurance companies aggregating up. This is a fight to see who controls the dollars at the high end. One other side comment I'd make on that, it's very interesting, and you can see this in different business journals. A lot of talk from an antitrust standpoint about trying to control the health systems as we continue to grow. I find it stunning that no one ever did that same discussion around the insurance companies that are so much bigger than the local healthcare systems. And for the most part, here's these big tax-exempt nonprofit healthcare systems, and we're getting punished. Now, that's my crying story, but I hope you'll feel my pain.
Chris Morrison. I'm a healthcare architect, and one of the things that has been interesting in our industry, watching what impacts how hospitals and healthcare, community health centers are done, or the whole reimbursement model that drives the economics for your industry. And you touched on it just a minute ago, a little bit about your engagement in insurance. But one of the things that I think has been very interesting is that it's gone from a transactional model where healthcare systems get paid for specific treatments as opposed to moving into a world where they're taking care of keeping a population well. And can you talk about that a little bit in terms of just how that's driving some of this decentralization from acute care facilities into more distributed health models?
So again, connected back, this move to managing populations, because we'll get paid for value, not volume. That's the vernacular inside the field. We got paid for volume, right? Units, clicks. And we're moving toward value. So how did you keep a population healthy? How did you actually have an outcome on what you did that actually was what it was supposed to be? And you're seeing all kinds of issues around that. And so we're building out a system to support that. That's how MedStar goes from 70 to 300 sites of care as we think about all the issues I've already talked about. The hard part today, and it ties back to leadership, if we went from where we used to be to 100%, we get paid on a value basis, a population basis. You'd have to be all in. In some respects, the leadership challenge would be easier because that's it. That's the world. It might crush the financials for a while, but leadership-wise, it'd be clear. The problem for us today is, as I talk to you today and we're thinking strategically and we're looking at where the future will be and your 5-year out question. In today's world, if my CFO were sitting here, she would say, but Ken, that's about 20 to maybe 25% of the revenues if I stretch for you. So don't drink all that strategic juice yet because we're still running the trains on doing whatever unit of service is there. So we're in this period. And I think if I looked across the board at my colleagues running other health systems across the country, you can see the gradations of leadership, back to what we're talking about this morning. Because if Ken Samet's only trying to lead MedStar for whatever period I'm fortunate enough to stay in this job, we actually don't have to do all these complex things. Like we could run yesterday's healthcare system and we'll run it fine and we'll be really good. And the organization will do just fine for the next 5 years. And 5 years from now, the organization will not be positioned right for whatever's coming next. And I think that's one of the real requirements of leadership. At some level in these organizations, I'm doing a few things for how MedStar runs today, but really the board and the organization are paying me and counting on senior leadership to do the right things for tomorrow. And so, but that's the moment we're in. And so I can make sense of that without question, and I believe it in my core. As you get all the way down to the front line, and this is the leadership challenge, and you go walk on a nursing unit and you talk to a nurse who's the hardest job, the most important job in the U.S. healthcare system, and knowing what they're dealing with minute to minute, and yet they're watching changes and resources get invested in ways that don't really touch them. You're selling a future piece, but here's their world, and they're trying to do the right thing for that patient. That's a complex moment where leadership or communication, where not ignoring what they're saying because it's right through their eyes, and just trying to give them enough to reflect and think about it. And I think that's the struggle of the day, but it's a struggle that you have to go into head first on that, because that struggle is not going to change whether you choose to engage or not.
I have to ask this quick question here because you raised something that has been bouncing around my head for a while. This notion of, so we're in this sort of disruptive environment as we talked about a little bit earlier, but you've also got this leadership notion in some camps of, well, that's the next guy's problem. And it seems like there's some clash coming from a leadership perspective on those two issues. And you just kind of outlined it. So you still view leadership as, it's not the next guy's problem. If the next guy has a problem, that's actually a reflection.
100%.
Okay.
So listen, if you spend, all of us, right, we spend so much time leading the organizations that we're in. And I had this experience once in my career. I'll just let that sit there. If you spend all this time and then the year after you were at whatever organization you were leading, if it's not doing as well and somebody says to you, well, it's not the same since you left, stop and think about that. That's actually not a positive comment. That's an indictment on your leadership. And we're doing this for the future. We actually earn our keep because of what we build for the decades to come. And that's the only way actually to both justify where we are, and I think it separates leaders. Leadership matters. I mean, I strongly believe that good leadership, bad leadership, you will see the results in the organization. It's not to suggest that the greatest leaders could just simply jump into any situation and make anything work beautifully, because underlying circumstances and the like could be really difficult, but they'll make it work a lot better than bad leadership.
Right.
And so, and ultimately for organizations that have a fair chance to be important for the future, well, then leadership's going to determine so many things. And then strategically, we're making certain bets. We made certain bets on where MedStar would go, on how we saw directionally the future of healthcare. You have to have the courage then to back that up, to invest, to stand the course when maybe it's not going as well as you wanted, when others from the cheap seats can clearly say, I don't know why he's doing that, look at this and today. Because in the immediate term, somebody's always got a factoid to say that can't be right. Okay? You have to be above that and have the courage to know, this is my role. I know where the board is. I'm trying to be communicative. I've got a leadership team, not just Ken Samet walking the tablets down. I mean, this is a leadership team that thought together based on all the facts we could get. And it's why, to me, this strategic exercise that we're in now to try and put the next stake in the ground for 10 years out, we might do 7 based on how changing the world is. We're not trying to get it precisely right, but we're trying to have a true north on, driven by certain key issues that we can share with folks. And then comfortably, what I've started to do over the last 3, 4, 5 years, for those that always want a challenge, my comment is, tell me which direction you want us to go. Because if the only thing you're saying is, I just want to hunker down and do nothing different, I'm certain that's wrong, right? But if you have another pathway that's better, easier, more, come tell me, because I'm looking for that. Yeah. And by the way, I'm still waiting for anybody to answer that pathway.
Timothy Johnson, LGW, Class 18, making a scene. Thank you, Ken, for coming here today. And
remember, whatever you ask me, I'm going to ask you at the United Way board meeting.
Absolutely. I'll keep it short. Thank you for sharing these pearls of wisdom with us. We often tell our students and our young people the importance of mentorship. I'm curious to hear, could you give us an example of a mentor that's been particularly impactful in your life and how that has played out in your career?
So I think that we all have a reason to give back, to pay it forward. You can use your words, but we're all here because somebody actually grabbed us a little bit by the back of our shirt collars and said, we're going to help you along the way. Somebody opened doors. And to me, it's some of the most rewarding work that all of us get to do. I'm not going to bore you with the long story, but a long time ago in the 1990s when I was running the Washington Hospital Center, the hospital center was one of 18 hospitals across the country. Tamara Smith, who was actually at the hospital center with me, may remember these times. We had a Commonwealth grant. It provided mentorship opportunities, 25 young people from one of the challenge schools in the city. I had a young man, Richard Jones, who became, we had a mentor-mentee relationship. Really good young kid, 9th grade, critical year, came from a broken family. And he would come to the hospital and do his homework there, and everybody kind of took him under our wing. We helped try to give him examples of how education would make a difference. We tried to give him folks he could see himself in that are successful inside MedStar. My kids got to know him, which was really important because your children don't know what they don't know, and so they think their world is actually the world at that stage of life, and they don't understand that they're lucky and they just don't know it. And anyway, the end of this story, and we've stayed in touch today. He's 39 years old, he has a master's degree, has 2 kids, and all of those, and he's doing other issues. So for me, it's deeply personal, and I think as an organization, our people are out in so many different organizations. And I think if all of us touch 1 or 2 folks, that's all we have to do. If you do more, God bless you. But there's just a lot of folks, and we all know them, that think that they are where they are because of them entirely, and they forgot how much this matters. And I think because of how big our platform is, whether it's taking kids across our platform every summer from the mayor's summer youth program, and then what happens from there? Is it just, and we try and match it up carefully because there are some folks that just check the box and say, yeah, I had a summer youth, I did it. Did you put personal time into that? And for me, the reward back, I mean, when I talk about Richard to this day, okay, I feel good about that. I hope he does, but it's like it's something that it will always be on my bucket list.
Last question.
Okay.
Kevin Reggie, Ken, thank you very much. Class of 13, living the dream. My wife, I should say, at the outset, is a 2-time cancer survivor. She received the lion's share of her heroic care at 2 of your hospitals, Georgetown University and Washington Hospital Center, and our family is very grateful for that. United Medical Center and the replacement hospital, can you speak to the current posture of the back and forth there, where we are now, and whether MedStar could have a role in that, in a variety of settings in terms of making those contributions from both a business perspective and from a community and healthcare integration perspective? Thank you.
You're welcome. So I'm really glad that we took care of your wife. We're always here for you. And I want to thank you all for having me today. Oh, there was a question that you wanted me to ask. I know, Kevin, you were looking at me. You were wondering, did he not hear me? So the issue of healthcare in the city at this moment has got a lot of complexity to it, as you all know from the papers. And I'm not in the middle of some of the back and forth between GW and the mayor and the council and United Medical Center, so we'll let that sit as it is. What I'd say from a MedStar standpoint is we're the leading provider of care in the region and clearly the leading provider of care in the district. And so we've always been and always see ourselves as part of the solution for healthcare in this city and this region. There can't be a solution for healthcare that doesn't include MedStar. It's not a boastful comment. It's just, I wouldn't make that same comment in Baltimore City, but it's obviously the answer here. And we've been proud to be part of that for a long, long time. And along with Howard University, the Washington Hospital Center provides the most charity care of any organizations across the region. Again, proud that that's part of what our mission is. And we take care of all kinds of walks of life that come in that need our clinical care no matter what their economic strata is. And all of that continues. Then you get to the politics and the organization of care, and that's complex. There's no question but that there needs to be a better, more cohesive approach to care in Ward 7 and 8. There's solutions that are needed. We could be part of some of those solutions, and we've certainly had those discussions over time. This situation is obviously active, and that'll have to play out on its own, and we'll see what takes place. So we're not in that discussion at this point. That's a GW, City, UMC, Howard University solution. If they figure that out, it'll go forward in whatever way it does. If it blows up, then I suspect that there'll be lots of other discussions around what should come next. I think, as you all have seen, Howard University Medical School is a really important part of the solution that has to be considered for so many important reasons. And then the question will be, can we take the politics out of the discussion and get back to that care discussion? We talked about that at the federal level. We'll need to do some of that at the local level to figure out what's the best way to make investments, how do we use resources, with a focus on how do we improve healthcare from for the residents of those areas. So, and only one other comment I'd make, you didn't ask this, but in this mix, you also are watching that Ascension's closing Providence Hospital. Again, that's a really challenging, troubling, unfortunate situation for a hospital that's been here 150 years, owned by the biggest national Catholic healthcare system. They've been part of the fabric of this community, though, particularly providing safety net and other support services. And make no mistake, that's an impact as well. So it is a very challenging time for healthcare in the district, particularly for a certain portion of the district. And we play across all lines of this. And so a lot more that still has to come. But I hope that thoughtful conversations happen, focused on healthcare needs. Secondarily, let the politics play where they might.
Yeah, thank you very much. Let's have a nice round of applause.